Okay, is everyone done? I think they're passing them forward. Okay. Thank you. I'll grab yours at the end. Oh, thank you. Perfect. See some random words up there. So, like Dr. Shelley said, I'm Josi. I've seen most of you around. It's been a while. The next year of your life will go by really quickly, I promise. It's a lot of fun. I'll hang out at the end if you guys have any questions about fieldwork or Capstone. I'm happy to chat about it. But today is about interprofessional practice. So, as you guys all know, Capstone has a lot of hoops to jump through. So, I have my objectives for my project listed here. So, my goal for you guys is to be able to identify the benefits of interprofessional education and practice, to demonstrate successful communication in those situations where you're communicating with other disciplines or within students, like amongst yourselves, with PA students, whatever it may be. Experience a higher comfort and confidence levels when you're having those conversations. I know that it can be really intimidating going into healthcare situations. As a student, you're kind of the bottom of the totem pole, especially with OT when not a lot of people know what OT is. You're kind of at a disadvantage, so hopefully this program will kind of help you guys gain a little confidence in that area. My goal for myself is to provide effective material for you guys to make it exciting and engaging and effective. I guess that was my second one. Yeah, a couple more. I hope this whole program kind of guides you guys in order to build communication and effective relationships within healthcare. And then finally, the assessment. I hope you guys have reported that you guys improved in those areas, that you are more ready for interprofessional practice, and that you see a higher value in it. So, terminology, super fun part. Interprofessional collaborative practice. I'm not going to say the whole thing every time. It's going to be IPC. IPE is interprofessional education. There's lots of acronyms, lots of long words. So, IPC is when multiple workers from different disciplines work together comprehensively to communicate with patients, build things together, communicate with families, and amongst the team. Interprofessional teamwork is what they're actually doing. So the practice is kind of above that, and then the teamwork is the level at which they work as a team. So if they're coordinating care, if they're cooperating together, if they're co-planning, co-treating, things like that, that would be the element of teamwork. Interprofessional education, that's what you guys are doing. Technically, this does not count since we don't have another discipline of students in here, but from what I've heard, you guys are working on that. So I'm kind of navigating that a little differently and having you guys fake it on Wednesday. So that's when one or more disciplines or two more disciplines come together and teach each other. Interprofessional team-based care, another term that kind of gets lost in there and can be misinterpreted. This is actually very coordinated teams. I have examples of like an ER team, OR team, palliative care. So those are actually just different disciplines working together for something very specific. So I think this is actually where a lot of IPC started, is organizations recognizing that they needed multiple disciplines to reach a goal. And so they started, but in this case, each discipline kind of has their own focus, where in interprofessional collaboration, the patient is the focus. Does that make sense? Okay. If you guys have questions at any point, raise your hand. I want this to be really interactive because I know I've been in your seats, literally, and I know it can get boring. So ask questions, make statements. Let's make it fun. Multidisciplinary. This one is very confusing between interdisciplinary and multidisciplinary. This is actually probably the standard, and hopefully we're shifting towards interdisciplinary. This is where healthcare disciplines do interact, they do work together, but the goals are more focused on their profession and not the patient. So that becomes a problem when there's someone like a complex case. If they have to see a neuro consult or whatever it may be, each physician is working on their own goal and not communicating as well as they would in an interdisciplinary. So I go to Clinic 1, they treat what they do at Clinic 1. I go to Clinic 2, no regards to what they did over here, treating something separately. Where in interdisciplinary, it's all kind of working together. In an ideal world, communication would be open. We wouldn't have, I don't want to say that we wouldn't have like HIPAA and privacy laws, because obviously those are important, but sometimes those do hinder communications between disciplines. Once again, the interdisciplinary team is a shared responsibility and goal of the patient, and again, multidisciplinary is when they have their own goals. Let's see. Okay. The Interprofessional Education Collaborative, more acronyms, IPEC is what it might be IPEC, I don't know. I call it IPEC. This was a collaborative formed in 2009 by 6 national associations for schooling. I believe it was like pharmacy and nursing. It was just those 6 professions for a while. In 2016, they actually included AOTA. So it took them quite a while to incorporate more professions, which now we're glad that they do. I think they're up to most healthcare professions now. Still, a few of them are kind of on the back burner and not joining the collaborative. But their goal is to establish standardized and broad competencies for any IPE program. So they are kind of the AOTA of IPE. So they get together, they have this national conference every year, they talk, they design programs, they do probably like CEUs for teachers to come in and learn about these programs. So their competencies are used as a standard, which I have them here. So standard number 1 is work with individuals of other professions to maintain a climate of mutual respect and shared values. Anyone know what that means?
What's your question again? I'm sorry.
Like, how do you interpret this? I know it's pretty straightforward, but just having conversations about it. Yeah?
Ensuring the health and well-being of the client comes first when coming up with different treatment plans.
Yeah. Anyone else? Yeah.
Similar to what Paulus was saying, is just everybody being on the same page about client-centered care, and also respecting the roles and responsibilities of the different interprofessional members of the team.
Yeah, Amanda?
I was going to say something similar about respecting what the different expertise that people bring to the table.
Yeah. So we may have our scope of practice, which is something I'm going to cover later on. But what we're doing should never interfere with another discipline. They should work congruently. So I know that's pretty hard sometimes when boundaries are blurred or there's so many moving parts into patient's care. But as long as we have respectful interaction, things will go a lot smoother. The second competency is use the knowledge of one's own role and those of other professions to appropriately assess and address the healthcare needs of patients and to promote and advance the health of populations. So that kind of goes hand in hand with the first one, and what we've discussed is using our own knowledge and respecting the knowledge of others to kind of have that broad aspect and coming in and using all of it in patient care. 3, I know you guys can read, so I don't have to read all of it out loud, but communicate with patients, families, communities, and professionals in health and other fields in a responsive and responsible manner that supports a team approach to the promotion and maintenance of health and the prevention and treatment of disease. I'm going to get really good at reading out loud after this, I guess. These are all pretty standard. There's not anything too complex about these. They're very broad because they are addressing all health professions, and so they wanted to create something that is all-encompassing. And the fourth competency is apply relationship building values and the principles of team dynamics to perform effectively in different team roles to plan, deliver, and evaluate patient population-centered care and population health programs and policies that are safe, timely, efficient, effective, and equitable. So this is the first one where the relationship building comes into effect. So we're going to talk about that and what makes a good team, but this is also addressing patient and population. So this is saying that IPE and interprofessional collaboration isn't just effective in a single patient. If that's applied in a broad range, it also helps the population. So this is kind of their diagram that they use. So everything that goes into patient-centered care and effective teamwork is going to be values and ethics. We each have our own, but also medicine in general and healthcare have their own broad ethics and values. And so each profession kind of falls under those as well. As long as we're following those values and ethics, we'll be good. Understanding your role within your profession and your team. Communication, pretty important. And then teamwork and team-based practice. So again, just valuing that a team can approach a problem better than an individual person. So, show of hands, who likes working in group projects? You guys can be honest, I am not one of those people. I don't enjoy it. I am a control freak, and so working with teams is not my strong suit, especially when I don't get to choose who I work with. Not that I didn't love all of my classmates and work wonderfully with them.
Both of these things are true about Josi.
Yeah, yes, he knows. But I think everyone can acknowledge that even if you don't like working in a team and you don't like group projects, you learn things from other people or you see perspectives that you may not have had before. And I mean, compromising, not my strong suit, but in the real world, it's something you have to do, which is unfortunate sometimes. So, like I said, we all have our own competencies for each profession. So even in our ACO standards, it addresses IPE. So I kind of highlighted the important parts. As students, we need to learn to support a team approach to promote health and wellness. And then we also need to demonstrate a knowledge of the principles of team dynamics. And so we wouldn't have been accredited as a program if somewhere in all of our material we didn't address IPE. So all of the case studies that you guys have done, you recognize that you wouldn't have a client if they weren't diagnosed with something or referred to you or going through something. So it is just this big wheel that keeps turning that at some point you guys are going to interact with someone, not just your patient, but other healthcare disciplines. And then our mission statement, one of the threads is to value interdisciplinary therapeutic approaches. Also, in our code of ethics from AOTA, this was just a handful. I think that you could argue for any of the standards of conduct or ethics that they discuss could be tied back to valuing patient-centered care, interprofessional education, and collaborative practice. All of it is kind of tied together. So quality of care and safety for clients is going to include recognizing what other disciplines are doing in care. Respect the practices, competencies, roles, and responsibilities of your own profession and those of others. That one's pretty straightforward. Let's see. Provide services that are in your scope of practice. We can't do anything that's outside of our scope of practice because that's not what we're trained or licensed to do. So by recognizing that, there must be someone out there that is able to do those things. And then finally, autonomy. This one, maybe not directly related to collaborative practice, but shared decision making. In this instance, it's talking about including the patient or client. That's number one with interprofessional collaboration is patient is the center. They are included in all of the conversations, and each discipline is recognizing that the needs of the patient come before the needs of what each discipline is trying to do. Does that make sense? So, the importance of interprofessional collaboration. So, I am not an expert in clinical care yet. I have very little experience. As you guys know, I've only done field work, but I have done a lot of research on this. And there are so many different studies that go over IP and collaborative practice, and the World Health Organization recognizes the importance. I think every organization, AOTA has this whole stance, and they do presentations on it consistently about why this is important. So, successful teams improve the quality of healthcare. Anyone have a guess why? Yeah.
I would imagine that it keeps people from returning for recurring issues that they're having.
Yeah.
And it also acts as a preventative measure
Yeah.
for the general population.
Yeah. So improved healthcare, kind of important. Does anyone want to guess what the healthcare expenditure was in 2019? Take a guess.
3 trillion.
Close. 3 trillion? 8. $3.8 trillion in 2019. I don't have the statistics for 2020 and including COVID. I don't want to know. But does anyone want to take a guess at what the expected expenditure is by 2028?
8 trillion?
Not quite. It's almost double. It's 6.2 trillion. And I'm here, I'm not like a math whiz. I can't even imagine that number. I don't even want to know. That's like if I dumped 50 pounds of rice on the ground. I don't even know if that comes close. No idea. I don't even know if I want to know. But by effectively solving problems, prevention, successful communication, we're going to keep patients out of out of needing care. And that's really important. Collaborative practice, like I said, the focus is the patient, and that's really important as well. It allows conversations and science to keep evolving. So if you're consistently communicating with other OTs or PTs or anyone else in whatever situation you're in or whatever practice you're working in, you're going to learn more knowledge. You're going to be kept up on evidence-based practice, buzzword right there. That's important. And like I said, when you're working in a group, you're going to know more together than you are individually. You're going to approach problems from different perspectives. You're going to have different ideas. And that's ultimately better for the patient, especially in complex cases when there's not always a cut and dry answer. And then this goes back to healthcare reform. So coordinating care with the aging population. So the aging population is kind of the idea that the generation that is approaching retirement and increased health needs is bigger than it ever has been, and it's going to keep growing. So each generation is getting bigger and bigger than the one before it, especially boomers. There's this whole large population that's going to need care and not enough healthcare providers. And so if we work on prevention, effective, I can't remember the word where if you stay out of, I think it's mostly a prison, if you stay out of healthcare and you're successful and you don't go back in. Yes, recidivism. Is that how you say it? It's, yeah. Yeah, I think I don't know if that's actually the term for hospital care or just prison, but one of my classmates was doing their capstone on inmates, and so that's why it popped in my head. But with their increased age, with the increased population, obviously older people have more healthcare issues. I think that's a standard fact. And it's only increasing as they age. And so addressing those problems early on and effectively is important for healthcare reform. Does anyone know what a sentinel event is? And it's okay if you don't. I did not until I started this research. Hiram.
I think it's like a preventable medical event. Like if you were in a hospital and I don't know, this happened to us, a doctor gives you an epidural without talking to another doctor, and it turns out that your blood pressure was too low, and so it causes things to go blah. Like,
Oh no.
yeah.
Kind of. Does anyone have another idea? Yeah.
Adding to exactly what Hiram said, but it has to result in grievous injury or death.
Yep. So a sentinel event, while yours is traumatic, yes, I agree. A sentinel event is something that it's involved in patient safety. It results in death, permanent harm, or severe temporary harm. So if you look at these statistics, this is like my big moment. This is my least favorite statistic, but something super important. 66% of sentinel events were due to poor communication. That's insane. That means 66% of all sentinel events were possibly avoidable. You had a question?
And this is ineffective communication between disciplines,
Yeah.
not just on the team.
Yep. Yep. So this is within a healthcare team. This is in, I don't think it goes quite into detail about it, but like communication within charting or with admin within a team. So 66%. I think that's absolutely absurd. And then I guess that was 2005. So 1995 to 2005, still an issue in more recent times. So 2010 to 2012, top 13. I think that's an issue. Yeah.
Other than, and you don't have to necessarily have this answer, but other than the communication piece, did your research find any other factors that might influence the lack of communication?
I didn't, but that's an interesting point. I might look into that and have an answer Wednesday, because it doesn't go into specifics of what the communication is. I think it's just in general.
I'll suggest that, with all of the productivity, you got to get here, you got to go there, and there's too much work to do, that people are just in their own little zone.
Yeah.
And they're not communicating because they just don't have time. I'm not saying that that's the only reason, but consider that.
Yeah. And we'll go over kind of the barriers to communication as well. This blew my mind. Okay, this is really long. I'll give you guys a minute to read it. I kind of bolded a couple of the important factors of it. Okay, I see lots of people looking around. This is just a hypothetical situation. This is from one of the IPEC conferences. This was a statement in their write-up. So it just demonstrates that, like I said, if you're only treating one issue with one person at a time and there's no communication between the two, I'm going to go have 5 visits and none of my providers are going to understand what I'm doing at everything else. And that is difficult to place the blame on providers if I mean, there's always going to be situations when patients and clients aren't communicating or advocating for themselves, and that's also a barrier. But with electronic medical records, this really shouldn't be such an issue anymore because this information should be available. So each provider should be able to see what Mrs. Jones is doing with one provider to the next. But I guess this is just an example and demonstrates how important collaborative practice and communication is in the grand scheme of things, and prevention and overall wellness and healthcare reform. So IPE, so the education, the stage that you guys are at with other disciplines and students. Hopefully, I know when I was here, there was talks of starting a PT program. I don't know where they are with that. Hopefully, Rocky kind of grows with more healthcare professions, and then you guys can, I guess not you specifically, but future classes can have a more in-depth experience with IPE. But the benefits of what we're doing today and Wednesday, or what you guys are doing with the chunks of IP that you guys are doing throughout the semester, it's going to increase your comfort level and your eagerness to work in these in these collaborative practices. It is going to help you learn how to communicate about OT specifically, but also your role in a team and just gaining that comfort. Because I'll tell you right now, sometimes even in field work, when you're working directly with an OT, communicating is still hard. I know I had troubles talking. I did 2 pediatric rotations. I had trouble talking to the parents and finding that line between telling how their kid struggled, but is also making strides towards their goals. Because no one wants to hear that their child is having a really hard day. But if that's what they did in the clinic, that's kind of what I have to communicate. So patients, families, other providers, it gets really complex really quickly. This opportunity, which you're going to have Wednesday, is going to allow you guys to practice advocacy for a discipline and communication with other practices, working in a team, and then also employee morale is not something that is discussed a lot with IPE or IPC, but I think that's also really important. Is if you're comfortable working with others and you're forced to work with others in your practice, you're gonna enjoy it more if you have practice with it. If you're just thrown into like a super complex team and you've never worked with teams before, it's gonna be really hard. And I don't think you have made it this far without teamwork. I think that's a given in any professional education, is that you've had opportunities to work together, but this is just enhancing that. So to promote collaborative practice, demonstrating the value of your discipline, especially in OT, we're going to talk about this later, demonstration, and whether that's through everyday practice, the goals that you set, and if anyone's going into research or publishing anything, having that evidence-based practice and demonstrating that is going to be really great for advocating OT, and this applies to other disciplines as well. Adhering to common systems and language. If you're communicating with other OTs, I think it is appropriate to use language of the OTPF. If you're not communicating with other OTs, they may not have any idea what you're talking about if you keep throwing out domains and things like that, and being very OT specific. So understanding how to communicate with other disciplines while still maintaining that healthcare verbiage, but expanding it a little bit, and also following the DSM, things like that, so everyone's kind of on the same field. Using evidence-based practice, I already mentioned. Recognizing the competencies established. So IPEC, most programs for education are going to go by those, as well as most organizations. Gathering evidence, measuring the effectiveness, and practicing and campaigning for IPE or IPC. So if no one in your healthcare team enjoys it and they are not promoting teamwork, it's not going to be successful. So if you guys are ever years from now in an administrative position and you are overseeing healthcare teams, gather evidence of the success of those and promote it. There's a lot of research about education. So at the stage that we're at, there's not a lot of evidence about actual practice besides healthcare reform and successful patient outcomes. That's about it. There's not a lot of ongoing research about team dynamics or like CEUs or in like luncheons when you do presentations. There's not a lot of evidence about that. So if you're ever in a position to do that, I say go for it. And then contact theory. If they throw you into the situation, that's the best way to learn. I guess you guys are doing mock clinics today. It's kind of the same thing. You're going to learn better by actually practicing things than me standing up here and teaching about IP. The actual experience is going to be better. But for my sake, thank you for sitting through this because this is my capstone and kind of important to me. So barriers to collaborative practice, we kind of approached on this. So absence of role models. If you guys go into practice and there's no one actually working in teams, you're not likely to just jump in, especially as a new grad, to like set that standard. That would be a little uncomfortable, I imagine. Funds and reimbursement. This is something that hopefully is veering towards supporting IPC. So no one wants to deal with insurance. I think that's a standard fact across all healthcare. That's the worst part about healthcare is dealing with insurance, in my opinion. I mean, sometimes families can be difficult or all of that, but just communicating with insurance is the worst. But we have to do it. So as long as you're following things and you're reimbursable, IPC shouldn't be an issue. But it's a barrier still, and especially in things like this, Rocky can't afford to fly out some random PT program to have an immersive IP experience or make drastic changes, and so that can be a barrier as well, just funding for things like this. Resistance to change. If you have an OT supervisor that has been in the field for 45 years and is like me and doesn't like change and doesn't like working in teams, you might not have a successful team in that situation. So there's always going to be individuals that want to keep with the norm, but it's proven that IPC is beneficial. Logistical factors, this is kind of like Dr. Shelley mentioned, scheduling or the time it takes to stop and talk to someone is going to put a damper on your productivity, which is unfortunate, but a factor to consider. So I don't know. I haven't worked in a place with productivity rates yet, and so I guess I could be preaching about something that I don't know yet, but communicating is still important, but your workload may not allow ample time to do so, as well as if in a hospital such situation, if you're on this shift and you're co-treating with someone that is working the opposite shift and you're never in the same place, something to consider. Defensiveness kind of goes along with resistance to change. If you have an individual that you're working with that is not great at taking recommendations or feedback, that can be an issue to communication. And then inconsistency in team involvement, I think also goes in with that scheduling logistical factors. Just if you're never working with the same person with the same patient, communication can kind of take a back seat. So this one we're actually going to do together. I gave some examples for what can improve interdisciplinary work. So you guys get to talk now instead of me. So does anyone have any factors that they would think improve interdisciplinary work at an educational level? So what you guys are doing now. Yeah.
Understanding like what other disciplines' role in that interdisciplinary team
Yeah.
is.
And like you
said you can't fly in a PT school or something, but through like telecommunication, maybe
Yeah.
having those IPs like we have this semester, but collaborating with other students to find out what like they do at the student level, what they're going to do in practice.
Yeah, absolutely. And I'll give you guys an example. Last week, I actually was involved with the University of Montana's IPE program. There were no OT students, which, like, next year I'm definitely going to advocate for you guys to be involved in that, or not you, I keep saying that. And myself and Molly Kimmel were the only representatives on, like, the facilitator for OT. And I came in like super last minute, so it would have only been one OT in the whole thing. There were over 300 students, one representative of OT. So I was a little mad about that, so I'm gonna change that for next year. Okay, what else for educational factors? Yeah.
I think also like having different, or like more versatile case studies to where it said like what either the doctor communicated or the PT on the team or
Yeah.
case managers. Things like that.
Yeah, definitely learning, how to approach cases just from not just an OT perspective, absolutely. Yeah.
Just like for Rocky, I guess in general, like we have the PA program here, so take more like advantage of having that program on
Yeah.
campus.
Okay, what about an organizational factor? So within institutions, clinics, hospitals, things like that. Devin?
Mainly gain opportunity for communication, whether
Yeah.
that be through like mandatory round meetings or things like that, or in the EMR system,
Yeah?
so that there's like a general comment section that'll be flagged every time it's updated.
Yeah. Amanda?
So I realize it's like healthcare is kind of like a business thing, but for leadership of a hospital or organization, to understand the long-term benefits of taking the time aside to have these
Yeah.
meetings.
Okay, anyone else for organizational? Hiram?
I think kind of like with that, also if your leadership is diverse and comes from different backgrounds, instead of like, because I feel like a lot of times healthcare leadership is just doctors, but trying to get like other professions in like big administrative
Yeah.
roles, I think could be very helpful.
That's a really good point. Okay, what about individual factors? So what makes you, as a future healthcare provider, OT specific or not, more willing to work within a team? Yeah.
I think there's just like a certain amount of humility that goes into like an individual. Like you have to recognize that other disciplines are as important as your own.
Yeah? Anyone else? So I put willing team members. Like I've stated many times, I'm not one for group work, but if everyone else in my group is also not excited to be there, that's only going to make it worse. And so I'm excited if the people that I'm working with are also excited. Yeah, Dr. Shelley.
I think just making it a priority to interact with other team members.
Yeah,
That little bit of time can be contagious, actually.
yeah. Knew that wasn't right. Anyone else? Yeah.
Desire to learn.
Yeah. I think that's a big factor why I chose this capstone is I have experience working. I worked as a CNA when I was an undergrad. I worked at a hand clinic with surgeons and hand therapists. And so learning from other individuals that are experts in their field was a really great experience for me, even though I had no desire to go into hand therapy. Learning from a hand therapist and surgeons was still really cool. I got to see a lot of things. It, I think, expanded my desire to learn, and that was a great experience for me. Yeah. Anyone else with individual factors? Yeah.
Maybe just opportunities for these experiences.
Yeah. Oops. Yeah.
The willingness to stay in the conversation even when it's difficult.
Yeah. And that, I think, is a struggle for everyone and pretty inherent, is nobody likes to be told that what they're doing is wrong or not what the team decides. And I think it can also be kind of a shutdown when you have this really brilliant idea and you share it with everyone and everyone's like, and you're like, I thought that was really cool, but okay, we'll go with the team, I guess. So, absolutely. Anyone with regulatory factors? So, reimbursement for collaborative practice, like I mentioned, yeah.
I was just going to say healthcare structure, like
Yeah.
in general. And I actually had a question, if you don't mind,
Yeah.
going back to the case
Mhm.
with Mr. Jones, and it was talking about their experience before the Affordable Care Act and afterwards.
Yeah.
Is there any, like, you're talking about research, is there any specific data supporting that that's more of like the outcomes now? Or is it more so like this is just like the idealized version of what we're looking for?
I think both. I think that with that hypothetical case, it was very much like in a perfect world. If we have collaborative practice, obviously everyone's going to be treated and there's going to be preventative measures and no one's going to need this. I think that's a little idealistic, but there is research post-Affordable Care Act that it is effective and leading to more desirable outcomes. Does that answer your question?
Yeah, is that recent or was that more, because I saw the citation was like 2011.
Yeah, so that was the last conference for IPEC put on a very specific conference, and that was the last time that was. I don't have any dates for you, but there are more recent studies that show that, yes. Does anyone else have any questions? Because I'm open at any time. Any more regulatory factors? Yeah.
I think the movement away from like the strict biomedical model is going to help with that a lot.
That I hadn't even thought of that, but that was a great suggestion, yes. Anyone else? Okay, we'll get back to it. So the skills that are needed for collaboration, there's like this little chart here. This was from IPEC as well. So communication, leadership, situation monitoring, and mutual support are all factors that are going to lead to successful collaborative practice, along with those positive attitudes towards teamwork, the knowledge from individual disciplines, and then just successful performance. So effective communication, obviously important in collaborative practice. Effective listening, still really important, sometimes harder than the talking part is the listening part. Shared decision making and conflict management. In my mind, those two go hand in hand. So shared decision making and conflict management, when, like I said, the team doesn't agree, sometimes you have to compromise. And I think you also have to be willing to suggest as much as you deny. So I remember when I was like 13, my sister wrote me this note about going into my teen years, and she said, if you're ever going to deny something, you have to make a suggestion. I think this was like hanging out with friends, and it's like, if you say no 3 times in a row, no one's ever going to ask you again. And I was like, okay, that's good advice. My sister's much older than me, so she taught me how to be a teenager, and that still applies. So if you constantly deny your team, or you're saying no, no one's going to come to you for good ideas if you're never suggesting anything. So in order to have shared decision making, you have to actually contribute. You can't just knock down other people's ideas. And for those that are less outspoken or aren't used to advocating for their ideas or for a team, that can be really difficult. Ability to give and receive feedback. This one is really tough as well. I don't know, are you guys still doing the peer feedback? Did anyone tell you that the first semester my class was a disaster? Yeah, it was bad. We had like this class meeting, to go over feedback, and I'm pretty sure people cried. It was not a great experience for anyone. And so we got a very in-depth talking to about how to give feedback. And it was important because even if it's anonymous, no one wants to hear someone attacking their character when it has no relationship to their work performance. And so having a working relationship with someone, even if you really can't stand the person, you still have to recognize their ideas and their contributions as something separate. I think it's pretty standard that there are going to be people in this world that you do not get along with, and that's fine. But you still have to be professional. Just throwing that out there. Our peer feedback got better after that first semester. And like the last statement, it is typical for things to come up that not everyone agrees. And so recognizing that situation may approach is important. And feedback and decision making is knowing that not everyone's going to agree all the time. So communication standards, this is very brief. The 4 most important things about communicating effectively is completeness, saying everything you need to say, but kind of keeping it concise. You don't want to go overboard, but you don't want to give too little information. It's clear. What you're saying actually makes sense to the person that you were talking to. It can make sense in your head, but if the other person doesn't interpret it the same, that's not clear communication. Brief, like I said, it's concise and timely. Timely for you, timely for the person receiving, and in the broad scheme of things. So if you are snagging someone leaving for their lunch break and you're like, oh, client XYZ needs this, and they're like, okay, yeah, but they're leaving for lunch, they may not remember. So you want to actually grab the person you're talking to when it's convenient for both of you and when it's actually valid. You don't want to communicate something too late after patient XYZ missed that opportunity. And then the subpoint is to validate and acknowledge information. So accepting information and making sure the person that told you knows that you heard them. Also really important. Like I said with the lunch example, I can't remember things if I'm like in a hurry, but if I say, yeah, got it, I'll write it down, then that responsibility is on me if I don't and I don't remember it. So we talked about barriers to collaborative practice. There's also barriers to communication. We've touched on most of these. Language, speaking language, native language, but also medical terminology also applies to this. So the way I speak to a patient is going to be different than the way I speak to a physician, vice versa. We also discussed in the University of Montana's language barriers, using children as interpreters. No. Sometimes it's the only situation you have. Sometimes it's the most convenient. But using family members as an interpreter for someone that does not speak English well or fluently in any means, not an ideal situation. I'll tell you why. For one example, they don't always say what you say to the person. Things are easily miscommunicated, mistranslated aside, and it just snowballs into a really bad situation. So I hope you guys all go into facilities in your practice that have opportunities for translators, and that isn't something that's placed on the patient themselves. That should not be their responsibility. It should be the responsibility of the facility. I've had good and bad experiences with that. So, distractions, pretty obvious. Proximity, I can communicate better with you than I can communicate with Kaylin in the back, especially if all of the people in the middle were talking at the same time. The method of communication, we've talked about electronic medical records, we've talked about face-to-face communication. They're all going to play a factor into how well you communicate. Personality, sarcasm. A lot of people like to talk with sarcasm. maybe not the best place in healthcare. Communication style, kind of the same with personality, the way that you talk. I am a hand talker, if you guys haven't noticed. So just the way they communicate is always going to impact that. Workload, we've mentioned. Shift change in schedule, also mentioned. Conflict. So I don't know if you guys go back to your high school days when playing games of telephone, not literally, but like gossip and all that. So if I'm fighting with you, but we have a patient in common, hopefully our communication is still professional and supersedes the personal conflict. And then lack of clarity or verification. Once again, going back to the 4 factors of successful communication, just acknowledging what you've heard and making sure that you've heard it right. Okay, that was a lot of information. You guys can take a break. 10:30, that's about 5 minutes. Me in the frame. Okay. Looks like there's a card going around, just so everyone knows. I don't know what it's for. Let's see. So, scope of practice. The next kind of section is going to go over different disciplines and what their role is in healthcare. So, individual scopes of practice are going to be the services as a health practitioner that you can provide. This is going to be based on state guidelines, your education, training, your experience, and then your demonstrated competency. It's defined by the state licensing boards, registration, and or certification. This might be a bullet on a different slide, but your professional scope of practice is always going to be limited by your personal scope of practice. And by what I mean is that is if you are not personally comfortable performing something, it should not be in your professional repertoire. If you can't get your own personal skills in that, even if it's on your scope of practice, it shouldn't be practiced until you demonstrate that competency. So you don't actually have to write down your personal preference about setting if you guys don't have paper out, but keep that in your mind. Does everyone have what their ideal situation is? Do you guys know how to talk about OT if it's not the setting that you want? I could talk all day about pediatric OT. Not so skilled in talking about hospital settings. So we're going to practice that. So if you guys want to work with a partner, whoever you're sitting next to as a table, kind of just a super brief explanation of something that you do not prefer. Go, because I will call on somebody.
Where it's not even a healthcare setting. Yeah. So how would you explain OT? Definitely great parents, parents.
Okay, 30 more seconds.
Including like helping your child in their main we can give an example.
Okay. Is everyone ready? I see you writing stuff down though. Okay, do I have any volunteers to first name what their ideal setting is and then give their example? Yeah.
We had a little group, so 3 of us, our preferred settings were acute or inpatient rehab, and then 2 in our group, their preferred were peds, so majority rules. So we did a little definition on peds that we would say in a pediatric setting, which is good because my first field work is in a ped setting, and I'm totally not comfortable with that.
Okay.
So we just said explaining OT to parents, we would say, OT focuses on helping your child successfully participate in their main daily roles, including self-care, play, school, etc.
Yeah.
Very general.
So peds is not your preferred? Okay. Anyone else? Not peds. We have another example. I don't want to like voluntold anyone, but I will. Yeah.
So my ideal setting is going to be like somewhere where there is a lot of other people working. Like I don't work well in like silos or isolations just because like I need to bounce ideas off of other people. So being an only OT or an only discipline in one setting is not my preferred, but my preferred is going to be like anywhere that is working collaboratively. And then I guess just like this short explanation of OT is just like I kind of categorize it for most people as like under the rehab umbrella and like explain what the difference between PT and OT is because most people know what PT is right off the bat.
Yep.
So like kind of going that category seems to give people a little bit more ideas.
Yeah. Out of everyone raise your hand if you have used PT, describe OT sometime in your life. Yeah. Yeah, everyone. I did this while getting my oil changed last week to like this couple that they were probably in their 80s and they're like they would not leave me alone and kept asking questions about everything and I was trying to read. And I just like kept trying to explain what OT was and they just couldn't wrap their heads around it, but that's okay. Not everyone's going to understand, but practicing explaining what you're doing or what your role is, even in situations like this, is going to be beneficial. And that's why I had you pick something you're not used to, because everyone's going to find their comfort, especially once you guys go to field work. You're going to be more comfortable talking about peds or wherever it may be, but kind of putting you out of your comfort zone for a second. So this is another long statement. This is actually from a student and something they said after an IPE experience. So the gist of this is OT can be overwhelming because we cover so much. We address every physical factor, environmental factor, personal factors. We have to look at a lot. And this student found comfort knowing that there are other disciplines that also have such a broad view of the patient that we don't have to focus so specifically on everything, that we do have a scope of practice. And it's comforting to know that even if you can't address everything, there are other team members that have your back and are going to do that. Yeah.
I just want to say a plug for that because I think that's just so essential to especially wherever you're working, to really know what other individuals do. So for instance, what a speech therapist does, or a physical therapist, or the PA, or whoever, and then be able to say, well, I know enough about this, but you know what, you are the expert. And that just builds them up, like, yeah, you're, and then when you do that reciprocally, it's magical.
Yeah, and I'm gonna go over different disciplines and their scope of practice, but going off of that, having that communication as you come into a team, whether it's as you are hired on as a new grad or as other people are joining a practice, saying, this is where my comfort is. This is what I'm really good at. This is what I'm going to look at consistently across all patients. And having your like standard go-to things that you do every time and knowing what everyone else in your team is going to do. And that way you can identify the holes in care and have someone address it. So you're not all addressing the exact same thing over and over and over again. If you and the nursing unit and the PTs all address the exact same thing 3 times a day, a patient's going to get really tired of that. And if they're completely missing everything else, then you have kind of this gap in care. So keep that in mind. Occupational therapy, our scope of practice. These are just broad statements pulled from AOTA, the OTPF, our standards of care, all of our regulating documents. You guys should all know this, but this is a great recap. This is a great way to explain it. So we use therapeutic activities of everyday living with individual people, groups, or populations to enhance or enable participation. Our services are habilitation, rehabilitation, promotion, and keeping health and wellness. And then we evaluate factors, ADLs, IDLs, health management, rest and sleep, education, work, play, leisure, social participation, whole 9 yards. You guys all know this. And then we provide interventions to address all those factors. So this is a really great brief slide. These are all statements directly from things. This is what we do. Fun fact, I have the Bureau of Labor Statistics numbers for all of the professions that I talk about. 126,610 OTs reported in 2020. I want that number higher. So communicating about OT, what are the strengths of our profession that make professional or interprofessional collaboration successful? So I have 3 statements. We focus on client-centered care. We provide the client with the opportunity to communicate, for them to self-advocate, things like that. And again, we encourage their inclusion in the shared decision-making. Does anyone have any other factors that they want to add to this list about why OT is great in including in teams? Yeah.
I think we were able to value other people on the team because we have that holistic picture.
Yeah.
So probably what the doctor says is going to be the same importance as what the social worker says.
Mm-hmm.
We are addressing every part of a person's.
Yeah, exactly. That's a really great point. Since we know so much about all of the broad factors, it's really easy for us to take all of the input from others and for that to make sense to us and communicate to the patient about it. Yeah.
And in that kind of sense, you could help be the bridge as far as like, okay, the social worker is saying this is an issue, the doctor's saying we need to work on this, so the OT can figure out how that can actually happen.
I think in both a team lens and a patient lens, an OT is a really great bridge, like you mentioned, between the team explaining to all the other professions or being that communicative factor between different disciplines and how they may not communicate well, and also knowing enough about what a physician and a social worker do and may say, and making sure your patient or client understands that. Any other ideas? Yeah.
I think we're really good at writing the lines between like the medical model versus more like kind of what you're saying, client-centered model.
Mm-hmm.
So again, adding to that bridge of being able to take into consideration both of those contexts.
Yeah, absolutely. Nice. So, stereotypes. I'm not encouraging or perpetuating stereotypes because I don't enjoy being stereotyped, and I don't think anyone does. But recognizing that they are out there is sometimes important. So, what's a stereotype of an OT?
Underwater basket weaving.
Yeah.
Patrick OT.
Yeah. That we're all working with games and play and things like that. Yeah.
We just work with hands.
Yeah.
That were female and white.
Yeah. I know. I have a lot of like super generic clip art on this slide. It is really hard to find medical professionals where they are not all male white doctors. Like, this, not a great representation in my mind. It was really hard to find. So if anyone finds a diverse animated picture of healthcare, save it, because you might need it someday. What about PTs? Sports, yep.
Jocks, yeah.
Jocks, yeah.
Ego.
Mm-hmm.
Buff white guy.
Yeah. Yeah, and I think also PTs and like athletic trainers kind of get the same stereotype a lot of time. Yeah. What about physicians? Ego. Heard that, yeah.
Older males.
Older males, yeah. What about surgeons?
Jocks.
Yeah. Has anyone worked with surgeons before? Yeah. Yeah.
A lack of bedside manner.
Yeah, absolutely.
Got complexes.
Yep. Okay, nurses.
They make
Oh,
the worst scientists.
what do you mean by that?
As in, they get stuck in their way of doing things and like aren't into new
Yeah.
research type stuff.
Yeah, there definitely can be. Yeah. What about nursing? Mean girls. Yeah.
Just like always busy.
Yeah. Run everything. Yeah. Okay. Any others that we should discuss? Any ideas?
Social workers.
Social workers. What's your stereotype about social workers?
Oh, that they just have. I'm just making a general statement. Don't pass it on to Rachel. That the social workers are just like overworked, way too many people on their caseload, and they have no idea what's going on with any individual. Because I've met some great social
Yeah,
workers.
I would agree that they're overworked, and that may be true in a lot of situations. So the reason that I bring this up is not, not trying to make light of it. It is funny and entertaining to discuss stereotypes, and I think everyone can agree that a lot of stereotypes stem from somewhere, but you can't walk into a professional setting believing all of these things and be a successful team member. I've worked with surgeons. I have worked with surgeons with God complexes. Yes, but not all of them. So kind of dropping that idea of whatever those preconceived notions, because I think you guys all know that not OT is all the same. We are not all the same. We all value different things. We're all different people. And so we kind of have to apply that to different things. It's easy to look at a profession and say they are this and this. And a lot of the times that may be accurate. We don't know. We don't know until we work there. So being respectful and going into a situation with an open mind is important. And I might run out of time today, so we can finish this on Wednesday. But going over different scopes of practice, physical therapy, and I know I learned a lot from making these slides, so I think going into this, you may think that you know a lot, but keep an open mind. There might be things that you learn from this, because I think we could all describe in general what a lot of disciplines do, but these are just to enhance your knowledge, for you guys to get a very direct look at what their governing board says. So for PT, they are grounded in basic behavioral and clinical sciences. They also have client management, much like OT, diagnosis and prognosis, which is a little different than what we are able to do. They optimize physical function, movement, performance, health, quality of life, and well-being across the lifespan. So I think that is something that a lot of people overlook when looking at PT, is across the lifespan. A lot of the times when you go to a PT, it's going to be for an injury or sports. That was something we discussed in stereotypes. It's such an acute thing that a lot of times people forget that PTs can go across the lifespan as well. So they contribute to public health, aimed at improving health population and the human experience. So much like OTs or public health workers can address population-based things, so can physical therapists. And their scope of practice, this is something I mentioned, is limited by their personal scope of practice. So this was something that was stated.
This on the web.
Thank you, Siri, telling me about PTs. This was something that their the American Physical Therapy Association specifically said, and I really liked it, because like I said, if you're not comfortable doing something personally, you shouldn't be doing it professionally. So our numbers was what? 160,000? 239,000. So much like our ACOT standards, PT also has the same accrediting standards that address IPE. So respecting values and ethics, communication, professional roles and responsibility, and teamwork, communicate effectively, professional obligations, so understanding their scope of practice and what they're going to do in an interprofessional collaboration. And I just like this whole statement: participate in patient-centered interprofessional collaborative practice. So, patient-centered. They also have those standards, so that's something to remember. Speech-language pathology. Their main goal is to optimize individuals' ability to communicate and to swallow, thereby improving their quality of life. So, I didn't know much about speech-language pathology. I think just kind of the basic knowledge that you gain from going to OT school, working alongside them, knowing that basic. So, reviewing their information was actually pretty valuable for me. They do a lot, actually. They address fluency, speech production, language, cognition, resonance, feeding and swallowing. I think that's something that most people do know. And then auditory habituation and rehabilitation. That would be is if you lose your hearing, rehabilitating to back to what you can reach, or habituating your new life without that hearing. So they also assess body function and structure. They're just more limited to what you need to communicate and to swallow. Activity and participation. So their standards also kind of look a lot like OT's. They're addressing a lot of things and a lot of factors, just in a more limited space. They're kind of closer to us, 148,000. Doctor of Medicine, an MD. So that is a physician that practices modern or allopathic medicine. I'll talk about a DO next. They have 44 identified specialties. So neuro, cardiac, all that jazz. 44 specialties is a lot. And they have, each of those specialties has their own standards. So if you guys have ever tried to really research a medical doctor, it's easier to define their scope of practice by what other professions can't do. So I'll talk about DOs and PAs and nursing. An MD is just going to do all of that and everything that everyone else can't do. So they have almost 1 million medical doctors in the US in 2020. And I think the DO is significantly less than that. I'll go on that next slide. I think we can end today discussing stop scope creep. So the American Medical Association has this campaign, I guess you could call it, that is #StopScopeCreep. That's hard to say. And that is the AMA advocating for medical doctors to have their standards of practice and PAs and nurse practitioners, to not encroach on that scope of practice. So I wanted to discuss with you guys what your thoughts are on that, both from a professional perspective and a patient perspective. So I can start it off with, as a professional, I like having my boundaries. I like knowing what other professionals' boundaries are and not intersecting those. So I feel important that I know what I can do and no one's going to interfere with that. But as a patient, why would I not want every medical professional to be as advanced as they can? So, thoughts? Yeah.
I instantly go to the emotional and financial underlines of this statement about how, as a medical doctor, the schooling and the effort you put in is significantly more than a PA.
Yeah.
I feel like for a nurse practitioner, that is a little bit more schooling and effort. So I could see why there's some like, don't step on our turf.
Yeah.
So whether that's a good thing or not, I don't know.
Yeah. I can understand every perspective of this, and I'm not trying to like antagonize their idea. It was just like this whole campaign, and the fact that they had a hashtag going for it was a little surprising to me, and I read a lot about it. It was very interesting. And I thought it was interesting to discuss with you guys, because we do have like quotas where we may be in charge of someone someday and they have their own limitations, and we work with PTs and SLPs that are someday those lines might blur. The University of Montana's rebranded their SLP program, and I can't remember the whole title, but it's Speech, Hearing, Language, and Occupational Sciences. And I thought that was really interesting. I haven't found anything in their documentation to why they include occupational sciences in their title, but I'm going to keep looking into it because I'm interested. So who can explain what factors may be involved in the stop scope creep? Yeah.
I mean, there's a duplication of services issue that underlies a lot of that, because I mean, if you have a nurse practitioner and a PA and a doctor all doing the same thing, but you're charging that client for the same exact thing through insurance, it becomes a problem. And we already have enough medical debt in the United States anyway, so duplication of services is a really big issue.
Yeah, that 3.8 trillion. Yeah.
I just briefly Googled it, but is it to focus on like stopping that doctor burnout? Is it to slow down burnout? Because sometimes doctors, like I'm thinking of it, I think in the reverse sense of doctors are given more patients and like that, I don't know, just more to do in general, especially with COVID. So it's increasing burnout because of the increased patient load. So I don't know, I think it could potentially have to do with that, because under the hashtag, when you Google it, it's kind of like set clear boundaries in your contract, say no more often, like things like that. So I think it's also
interesting.
Doctors.
Yeah, I don't know if I came across that perspective, but in my head, I don't know if that's congruent, because if there's more practitioners able to do the same thing, it would mean more patients are being seen.
Right.
And so that's kind of the incongruency there. But like you mentioned, reimbursement is going to be a huge factor, because we can't keep charging a physician fee for one thing if someone else is doing the exact same thing for cheaper. It means one of them isn't going to be reimbursed. And so that's an issue in itself. But the medical debt, yeah. So I was just curious what everyone's thoughts on that were. So we are out of time today. I have a few more slides to go over Wednesday, and then we're going to do case studies in groups. If you guys have any questions about this or fieldwork or Capstone, let me know. I'll hang out for a few minutes. But thank you, guys. Good morning. Hey, back corner. Hi, guys. Thanks for coming back. I know you guys don't really have a choice, but I appreciate it. I know I'm kind of a spaz when I present. I tell a lot of semi-relevant personal anecdotes, so I appreciate you guys laughing when I try and joke. I'm excited to be here. That's kind of why I'm all over the place, but I guess you will also be excited when you guys finally get to your capstone, so it'll go very quickly. We left off talking about medicine, so I'm going to go on to what a DO is now. So a doctor of osteopathic medicine. This is becoming more popular. It's pretty congruent with an MD. They just have a stronger emphasis on physical modalities, so they use all of the tools that are available to an MD, the same technology. They can still do diagnosis, surgery, all of the same qualifications. They just might take a step in a holistic manner before they diagnose or before they medicate or introduce surgery. So they actually have an average of, I think, 200 hours more focused on like anatomy and physiology while they're in medical school. So they have a very strong emphasis on OMT. So that's manipulative treatment, osteopathic manipulative treatment, which is kind of what we do when we like palpate, it's kind of in that manner. So it's using muscles and joints for stretching, using physical activity as a treatment method, using all of that to address pain. So this is a very beneficial option instead of going to an MD. Most of DOs are in family medicine. That's their strong emphasis. And let's see, they currently make up only 11% of doctors in the US, but it's 26% of current students. So like I said, this is gaining traction, becoming more popular. Only 135,000 DOs. The last slide, if you guys remember, it's almost 1 million MDs. So very small portion, but hopefully that gets integrated more, because I think this is a really great option for a lot of people. A physician assistant, not physician's assistant. I know it's hard to remember. PA, their national association doesn't even say, it just says PAs. They just make it simple. I think they don't want to draw attention to the assistant part because there's such a strong emphasis on that when that's not really their whole entity. Did you have a question?
No, I was just going to say they're actually changing it to physician associates.
Oh, cool. Yeah, I think appropriate. Yeah. So they have a lot of responsibilities. They can take medical histories. They can do examinations independently. They can diagnose, prescribe, all of that jazz. The only thing is that in every state of the U.S., they have to have a physician overseeing them, some form of oversight. Let's see. As you guys know, the PA program here is super fast-paced. Most of them are just around 2 years, 27 months or more, and a lot of clinical hours. They just throw them right in, and it's super hectic. I have a few PA friends, and they have no free time, which, I mean, in grad school, I think OTs, we kind of have that balance, which is nice, but PA, that whole field to me is just nuts because they learn so much in such a short amount of time, and they have so much responsibility. They are up there, 125,000 PAs in 2020, and we only employed 650 in Montana. That's total for the whole state. They're pretty, as you guys know, like even OTs we have hot spots in all the big cities. PAs are actually a little more spread out since they can practice. So they might be in smaller towns for family medicine, but that number was kind of sad just since we do have a PA program. I'm hoping that more PAs will stay in Montana. Nursing. So nurse practitioner, that was the word that I couldn't remember on Monday, but there's a whole hierarchy here. CNA is going to be the lowest since you don't have to have additional degrees for that. So an LPN, they can provide care under supervision. They monitor health status. They deliver basic treatments. That includes dressing, IVs. In some states, you have to have a special certification for that. Catheters. They can discuss care, and they're going to assist more than they are going to be in charge of something. A registered nurse is the next step up. So they assess, implement, and evaluate care plans with the team. So they have a little more responsibility. They can perform wound care, which is my worst nightmare. They prepare patients for exams and treatments in regards to an MD or a DO or PA or a nurse practitioner. They operate and monitor a lot of the medical equipment, and they educate patients and families more so than an LPN would. And here are the numbers. Lots of LPNs, almost 3 million RNs in the US, which is great. I think we still have a shortage though. And last, a nurse practitioner, they have the most responsibility, the most education, and are certified to do the most. So they can assess, diagnose, and manage acute and chronic health problems. So I think a lot of people assume that a nurse practitioner is going to be in a hospital setting like RNs and LPNs would, but they can also work mostly independently in family medicine, in clinics, all of that, because they have a lot of independence. They can order, perform, supervise lab tests. They can assist in surgeries. And prescribing medication, that's another thing that's up there with the PAs, DOs, and MDs. So nurse practitioners, they are an advanced level practitioner, and they're only 325,000. So I think that number is also growing significantly. Yeah.
So with the nurse practitioner, when they're diagnosing and prescribing medication, does all of that then also have to be passed to an MD or a DO or something?
I don't believe so, no. Yep, so they don't have to have specific supervision from an MD or a DO since they are an advanced level practitioner. It's just like surgeries in certain cases that depending on the complexity would go up, but they handle mostly everything.
And they can refer out to
yeah. Yep. Yeah, so a lot of the times I think in OT you're going to get a lot of referrals growing from not just an MD. Social work, I have social work and public health, which are both very broad fields, and so I stayed pretty brief with these. Social work, their primary goal is to enhance well-being, especially in regards to vulnerable populations, whether that's adults with like homeless adults or adults with any disability or veterans, things like that, or whether it's children from in the foster system, things like that. So vulnerable populations is their focus, but they are able to consult with a broad spectrum of people. They are going to focus heavily on the environment and personal factors and what's leading that person to being in that vulnerable state, and they're going to address those. So there's lots of specialties of social work. So clinical, I think, is what everyone's first thought goes to, but they also work in mental health, addiction treatment, community organizations, families and children, I think, is also another big one. That's, I think, clinical and families and children are going to be where the majority of social workers are, because there's a lot of, our foster system is awful, and so there's a lot of kids in those situations. I didn't mean to do that. Like I said, substance abuse, so like I said, super broad field. This is just a quick snippet. Public health, also very broad. Their main objective is to protect the health and well-being of populations. And so I think public health and social work go hand in hand. They're often confused, or you think a social worker is addressing something and it's actually a public health worker. So, and from a patient perspective, they can do a lot of the same things, but promoting health and wellness, encouraging health behaviors. So this is going to be like what our community projects have always been, addressing a broad topic for a wide variety of people. So self-care, healthy eating, like the food pyramid thing that we all learned in elementary school and that's still around, like that would be public health. So they're going to identify causes of disease and disability. This can be a specialty of like epidemiology, COVID, public health, biostatistics, environmental health, health policy, all of that. Yeah.
What's the typical, oh my gosh, education level?
I would say, I think there's a master's that is, depending on the job that you want, is what most people are going to get. There's lots of public health jobs that you can get with or without an advanced degree. There's just like a certain title that you would get once you earn a master's in public health. Does that make sense? So like a clinical, you would need that degree, but you could always work for a public health company. So I'm going to introduce some case studies. We actually have like a few discussion questions that I didn't get to on Monday. So that's kind of the end of my lecture. Let me pull out, I have a couple fun scenarios for you guys about communication. So this actually happened to me, and this was kind of an interprofessional collaboration. I was thrown into this. Okay, imagine yourselves a couple months from now, you get your first kid at a pediatric setting in your field work. You it's a new evaluation, and so your supervisor says, it's your turn. You get to do this one all by yourself. So you evaluate the kid. The next time he comes in, you're getting to know him, and you ask him, oh, what's your favorite meal? Or I think he asks you first, and you say, oh, I like spaghetti. And he goes, I like pizza and beer. 10 years old, I like pizza and beer. And I'm like, whew, okay. And I was like, what's your favorite meal again? Oh, pizza and beer. I'm like, okay, what would you do? What's your first instinct on that? And if you guys can't tell, this happened to me, and I panicked. My head was, pfft. Yeah.
I think just clarifying what they're actually meaning by beer, because it could actually just be root beer.
Yeah.
Because my little kiddo had a hard time saying root beer, so.
Yeah.
And it just sounds more adult-like, and at 10 you're trying to do
Yeah.
that.
You try to clarify, and they don't address the beer again. I'll just go with that. I clarified once, he said it again. Low cognition level, but very adamant that he likes pizza and beer. So I'll just tell you guys, I left the session. He left with his dad. My first instinct was go to my fieldwork educator, and I was like, so Bobby likes pizza and beer. And he's like, oh, okay. So who do you talk to? Yeah.
And like along Caitlin's lines, I think your first instinct shouldn't be like, oh, he's having pizza and beer.
Yeah.
But maybe mentioning it, like when he brings it up, saying, oh, that's funny, like when do you have pizza and beer? Find out a little bit more about it so that when you drop him off with dad, you can say, oh, Bobby mentioned today he likes pizza and beer. You
Yeah.
know, and maybe dad would say, oh, it's root beer or ginger beer or whatever type of beer. Ha ha ha. And
Yeah.
then if dad is like, oh, he's been saying that lately, you know, mention it to dad and then mention it to your
Yeah.
coordinator. You know?
Yeah.
Yeah, and then if it progresses to the point where dad like doesn't address it or anything, then like
Yeah, I think it's
possibly
weird.
going to like social workers and like getting maybe a case opened up
Yeah.
after that.
Yeah, so first step, don't call CPS. That shouldn't be like, obviously without talking to anyone, especially as a student. So I had the fortunate opportunity to work in a clinic that also had mental health services, speech and physical therapy, as well as OT. So although this kid was new for me, he had been seeing a mental health counselor for a couple months. So I went and talked to him. And I found out that he parrots things from his parents, and so he does not consume pizza and beer. His dad likes pizza and beer, and so he says that all the time. He also talked about how he drove his dad's jacked up F-150 all the time. A 10-year-old. Didn't happen. And so that is something, it could have snowballed. It could have been a terrible situation to be in, but since I had the opportunity to work with other professionals, I found out that the situation was not as catastrophic. But 3 weeks into your fieldwork as a new student, I was terrified. I was freaking out. So you guys are going to come across a lot of things that you may not be prepared for. Just take a deep breath. It'll be okay. It is still something that we reported in his note, just to keep track of it. In the S part of my note, that he stated something regarding alcohol consumption. Not very detailed, just something that we could keep track of. It is something that if it were to turn out to be a situation and you didn't address it, that would be a whole nother problem. Let's see. What happens in fieldwork if you are corrected by someone that is not your fieldwork supervisor? How would you guys handle that? Especially if it's not something that you agreed with. Yeah.
Then I'd talk to my fieldwork supervisor about it.
Yeah.
And run it by them.
Anyone else? I haven't heard from that. Yeah.
I was just gonna go off of what you said. I think initially that would graciously just hear what they had to say and kind of accept it, oh, thanks for the feedback. But then I would go and ask, just validate it with my fieldwork or not.
Yeah. Anyone else? Because I guarantee things are going to come up that are uncomfortable in fieldwork. So I'm just trying to prepare you guys. more questions. So raise of hands, who has worked with someone like outside of school that is difficult to communicate with? Yeah. Okay, does anyone have examples from like a healthcare job or field work? No? Okay, outside of healthcare or field work? Yeah, Amanda.
Oh, well, I mean, just stuff like, I mentioned, wow, it's really pouring outside. And then later on, when I was doing the dishes, the sun was shining in through the window. And I said, wow, I need my sunglasses for this. And then my coworker said, wow, you're not happy with whether it's raining or sunny. I thought he was joking until my client started saying that he was afraid I was going to cancel outings because I was afraid of the rain.
Oh.
Yeah, so I mean, like, it was a manipulation thing.
Yeah.
Coworker, yeah.
How did you approach it? Or did you just let it go?
It happened over a few weeks, so I didn't know to.
Yeah, no to address it because it was a slow building thing. Yeah. Does anyone else have examples? Yeah.
I feel like always working like the HUC or something on the hospital was like difficult for me, like because they are the lead of their entity of nursing or whatever.
Mm-hmm.
And, if I had to communicate with them from like therapy, it was always difficult because they're like they need to get better, but like they're also need therapy, and there was always like conflicting. Because I would make a schedule and I'd be like, we need to have this patient here for this. It was like every day a different battle with the HUC.
Just trying to get them to like go to therapy or
No, just basically like they thought like, well, I mean it is tough, but like they're like, well, they need this, and this, these times days. And I'm like, okay, but the PTOT speech therapist asked for them at these times days, like they're very conflicting. They weren't talking to each other, and they're like, well, I'm a therapy tech, so they're like, obviously their role is above mine,
Yeah.
even if I'm in a different role, but I'm like, but I'm also responsible to make sure they go to therapy, so it's always difficult.
yeah. So what do you do in those situations?
Hold on them. Always.
Yeah. It is hard, especially when we're coming into this as new grads. We don't want to be overzealous and be demanding when we're at the bottom of the chain. It's really hard to find that balance, but we still have to advocate for what we're doing and what our patients need. So that is a tough situation. There are a lot of things. Yeah.
Oh, I had a example to share.
No, I can be done talking. Go for it.
Oh, cool. No, just when Shelly and I were doing fieldwork, Shelly was my fieldwork supervisor for my first fieldwork. In one of the schools, there was members on the interprofessional team that were disagreeing with some of the things that we were doing that were sort of small, not petty, but smaller things that were apparently affecting the dynamic. But instead of talking to her and I directly, went to our mutual supervisor in order to like complain and try to hash things out. And then the supervisor had to like go and like try to run interference there. And there were things for which direct communication between her and I and creating some understanding could have easily probably resolved stuff. But the fact that they were going around that and going above just caused all this unnecessary confusion and a lot of just not animosity, but unnecessary emotion, tension.
Yeah, and I think that's something that even like we were taught our class, if you have an issue, go to the person first, and that can be daunting and overwhelming to kind of approach someone, especially if they have the issue with you. But if you notice anything, my suggestion is get it out in the open before it becomes an issue or goes to supervisors. Yeah.
I would say don't assume, ask. You
Yeah.
know, I just think that that's just key, because you could think something and then you're back meeting and then there's 5 of you and you think something but then you go directly to, you know, the source or the person, even as individuals, you very likely could be wrong.
Yeah.
And then you've all kind of gotten all sideways and you didn't need to.
Yeah. And if you have a situation where I mean, a client of yours is receiving multiple cares and there's an overlap, my suggestion is kind of hang back. If a PT is coming in to like a hospital setting immediately after you, see if they need help within the first 2 minutes and debrief. Talk about what happened. Don't talk about the client as if they're not there. Include them in the conversation. But creating those small opportunities to talk to someone are going to pay off in the long run. Because if you spend 2 minutes every day talking to this person before you move on, if there is an issue later on, it's going to be a lot easier to approach that person. Yeah.
Along those same lines, I would highly recommend become buddies with at least one PT in your clinic. And I don't mean just like acquaintances, because that can break down those barriers between the OT and PT, if there are any. Some clinics are just amazing and everybody works together and everybody understands OT does this, and we do this together, and but just even touching bases with, hey, how's so-and-so doing with you? How are they? And asking them, how far are they walking? How are the transfers? And then you don't need to toot your own horn, but you can just say, oh yeah, I'm noticing that too, or that's interesting. When we do this and this is what he's able to do, because then you're sharing, like that's for the best interest of the client. So
Yeah.
If in doubt, actually try to share.
Yeah, and I think, like Shay, in your situation, if OT were very subtly bragging about all these like links they're making with a client, then maybe the nursing staff is going to be more willing to let those people go at that time. If we kind of stay back and don't share any of our results with anyone, and no one knows like what's happening or what's improving or what's we're even doing with clients at all, then of course they're not going to be like, yeah, take him. They're going to be like, what do you do anyways? So subtly brag.
And this is just, so if you're in the hospital setting, also make friends with the CNAs.
Yes.
And the nurses, but just like being willing, I'm an OT and I don't have to clean the shower room. Clean it up. Do what you need to do, because then you're showing that you're willing to be part of the team. And answer that with those call bells. Give the people water. Take 30 seconds out of your life to do all those things. Literally, win friends and influence people.
Yeah. I was a CNA, so I can say, please do that. CNA is one of the most difficult jobs because you are the most underappreciated. It's kind of like, I worked in a lot of settings as a CNA and like maintenance staff, people don't even see them. It's really sad. So I would agree, they are going to be lifesavers in a lot of settings. CNAs do a lot, so don't make them mad. Nursing staff as well. Did you guys have the opportunity to go to Billings Clinic and do like the nursing? Okay. We did like a tubes and lines lab with Billings Clinic, and they kind of just went over protocols for changing things in nursing staff. And even they made comments where, as more advanced nursing staff, they're like, oh, the CNAs will do it. And I was like, oh, that's so cringy. Just help. Everyone needs to help out. So I think just going back to working with people that are hard to communicate with, it can easily lead to negative outcomes, whether that's like a retail job and someone's difficult to communicate with, you're going to lose customers, or just lower quality of care, I think can easily be a result of poor communication. So don't be afraid to address problems as they come up before they become bigger. Don't be afraid to ask people directly. The case where I asked if someone other than your fieldwork supervisor corrects you, I'm saying that because it happened to me. It was a very uncomfortable situation because I didn't agree with what that person was saying. I was doing what I was doing for a reason, but they've been an OT for 20 years, so I'm like, I was doing it for a reason, but are they always right? Not always, but having a conversation is going to have them have more confidence in you when you're able to justify what you're doing and explain your motives. And it's also, you're going to learn a lot from them and saying, oh, I've seen students do this and this for the last 20 years, and I didn't want you to progress and form this bad habit. So they're doing it for a reason, you're doing it for a reason. All you have to do is talk about why. My last question is, what is something that you could read in a patient's chart, but without the context of talking to any number of your healthcare team, be misconstrued, misunderstood, have negative consequences? Anyone? Yeah.
My patient is like needy.
Is what?
Like needy.
Yeah.
Reading someone's chart as like a comment. And
Yeah.
Be misunderstood, like with like pain.
Yeah. There's a lot of things. Yeah.
Oh, sorry. Like the client is resistant to like treatment.
Yeah.
So, you know, I've had experiences where PT wanted me to do stuff and I'm like, I can't do that. And that can come off as me being rejecting like what they're saying and rejecting care. And it's like, no. So like, yeah, that's a big one.
Yeah.
So, my last job, we had to go through the paper dragons or paper tigers training or whatever. And we were always encouraged not to read the history before we met the client. We always read the history after we met the client, because a lot of stuff in the history can be misconstrued, like, you know, sexual offenders or anything like that. That's a really big thing in the world.
Yeah. I think a lot of times in histories, whether or not you read it before, substance use is often read. You can read substance use and you're automatically going to think substance abuse. Very different. If you go into a room, if nursing staff goes into a room, an MD, and they see substance use and think substance abuse, medication is going to be this whole big issue when it may or may not be. Anything else? Something that you could read, but without any context, you kind of see it differently. Yeah.
I was gonna say kind of like, yeah, substance use, substance abuse, but knowing what the rules and policies are around that can really shape your opinion. So there was something about like if a mom has a baby and the mom has been using or has in the past used substances, there's like different rules that apply to like what happens to the baby or if the baby can go home with the mom. So you kind of have to like read it and also keep in mind all policies and rules at the same time, and also like what's the social worker saying about it, and like having that context instead of just like reading the chart and being like, oh, this mom's gonna be like this XYZ, like
yeah
you know.
Kind of along with layman's, but like just declining the service, and then also like just not showing up at like his outpatient services if you don't like specifically state like maybe why, you just always think they're flaky.
Yeah, and that's something I've worked in admin a lot, and there's a lot of factors that go into like no-shows or reschedules, and you can look at a chart and it shows you and it says like canceled, 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 and you're like, wow, this person has canceled 9 times in a row, but without context of it, like, oh, they were in an accident, they've actually been hospitalized for 3 weeks, they couldn't come, or our provider didn't show up and we had to cancel that appointment. And so there's a lot of things that can be misunderstood, and without conversations, the patient declining services could be actually they are in a lot of pain, or they're in a lot of pain but they're still willing to do things, or their pain is because they've been laying in bed for 7 days without moving and not because they have a low pain tolerance. Does that make sense? Okay.
Something that came to mind, it's somewhat related, but I also noticed too that, especially for Shelly and I when we were in the schools, that often if we were going to go see a kid and someone else saw them prior, that some staff would frame what our session's going to be like through their subjective lens of what they experienced prior. And so they'd be like, oh yeah, you're not going to get anything out of that kid today, he's not going to be willing, and so then you just set me up to like expect that to occur. And so many times we'd go in, we just knock it out of the park, and they did all the things that we asked them to do and more. And so being able to filter that, but also being wary of doing that to someone else too, and giving them objective data or observations that you saw and saying like, this is what they did for me, but not saying like, hey, this is gonna happen to you.
Yeah.
Because I
Might as well not try.
Yeah.
Yeah. And I think going along with that, if you, like, in any setting, if someone walks out and they're like, they're not going to do anything for you, they had a really hard day, there's still a lot of activities that we could do, even if they're not willing to get up and move around. If they're like homesick, if you're in a hospital setting and they aren't going home for a while and they are just super blue, there's still a lot of things you can do. They might not want to get up and jog around with the PT or get up and do anything, but you can still try. You can still talk to someone. Yeah.
I'm going to piggyback on top of that too. So you know what you want to do with the patient, but the nurse says, oh, you know, their blood pressure is low, I don't want them getting out of bed. So then you can, you know, re-pitch it to, you know, think on your feet, well, we could do something differently. And also, you'll find that people will want to define you, and you know that that's maybe too limiting, or that wasn't your plan. So, okay, OT is supposed to be doing showering, and they set you up for the shower. You're like, wait a second, that wasn't even on our goal list. You'll have to negotiate a lot of things, but educating people kindly, and then showing them.
Yeah.
Just show them what you do. Show them your stuff.
Yeah. And she brought up a phrase, thinking on your feet. Did you guys have to interview with the accreditation people? Yeah. I did too. They pulled some people from our class to do it over Zoom, and they asked me, like, what was the most beneficial thing that you got not directly related to like coursework? I don't remember exactly the question, but I was like, this program prepared me to have a plan to not have a plan. And that's something that's a little confusing, but you guys are a lot more prepared than you think you are to think on your feet. Going into any situation, it's not going to be how you want it to be all the time. And understanding that beforehand, I am a very systematical person. I like having a plan. I like following the plan. But I was really well prepared for that to go out the window. And you can handle it a lot better than you think you can. If I can handle it, you guys can handle it. Going over case studies, I want 4 groups. I don't actually know how many of there are, so like groups of 7, I think, however many you have. Okay. I have the case study, so if you guys want to split up real quick, I don't care who you work with. If you want to do like corners, or you guys can have a couple minutes to take a break and form groups.